A 72-year-old patient with a history of COPD and hypertension is scheduled for elective hip replacement surgery. Discuss the factors that should influence your anesthesia plan and the potential risks involved. Answer: when planning anesthesia for a patient with COPD and hypertension, several factors must be considered. Preoperative assessment. Assess the severity of COPD using spirometry and determine the patient's functional status, e.g., ability to perform daily activities. Obtain a complete medication history, including use of bronchodilators and corticosteroids. Anesthetic technique. Regional anesthesia, e.g., spinal or epidural, may be preferable to general anesthesia to minimize respiratory depression. If general anesthesia is required, consider using agents that minimize respiratory effects, e.g., short-acting neuromuscular blockers, and ensure adequate pre-oxygenation. Monitoring. Continuous monitoring of oxygen saturation and end-tidal CO is critical due to the risk of respiratory compromise. Postoperative considerations. Be aware of the increased risk for postoperative respiratory complications. Ethical considerations. Informed consent must include discussions about potential risks, especially related to respiratory function and alternative anesthesia options. Describe the ethical implications of informed consent in the context of anesthesia, particularly regarding high-risk procedures. Answer: informed consent is a fundamental ethical and legal requirement in anesthesia practice, especially for high-risk procedures. Key implications include autonomy. Patients have the right to make informed decisions about their care. Anesthesia providers must ensure patients understand the risks, benefits, and alternatives to the proposed anesthesia plan. Disclosure of information. Providers must disclose relevant information, including potential complications, e.g., awareness during general anesthesia, respiratory complications, the likelihood of those complications, and the risks associated with not undergoing surgery. Comprehension. Assess the patient's understanding of the information presented. This may require adjusting explanations based on the patient's literacy level, cognitive status, and emotional state. Documentation. Proper documentation of the informed consent process is essential. This should include details about the information provided, the patient's questions, and their understanding of the procedure and risks. Legal considerations. Failure to obtain informed consent can lead to legal repercussions, including malpractice claims. During a surgical procedure, a patient experiences a sudden anaphylactic reaction to a neuromuscular blocker. Outline the steps your team should take in response to this crisis. Answer: in the event of an anaphylactic reaction during anesthesia, the following steps should be taken. Immediate recognition. Promptly recognize signs of anaphylaxis, including hypotension, tachycardia, wheezing, and skin reactions. Stop the offending agent. Discontinue administration of the neuromuscular blocker immediately. Activate emergency protocols. Call for help from the anesthesia and surgical teams and ensure a crisis resource management plan is in place. Administer epinephrine. Administer intramuscular epinephrine 0.3–0.5 mg of 1,000 solution as the first-line treatment. Repeat every 5 minutes as necessary, depending on response. Supportive measures. Provide oxygen and ensure the patient is in a supine position. If hypotension persists, consider intravenous fluid resuscitation and additional vasopressors, e.g., norepinephrine. Monitor and document. Continuously monitor the patient's vital signs and airway. Document the event thoroughly, including time, interventions, and outcomes for future reference and quality improvement. Discuss the role of continuous quality improvement (CI) initiatives in anesthesia practice and provide examples of successful implementations. Answer: continuous quality improvement (CQI) initiatives play a critical role in enhancing patient safety and care in anesthesia practice by identifying areas for improvement. Regular audits and data collection can identify trends in complications or areas where patient care may be suboptimal. For instance, tracking the incidence of postoperative nausea and vomiting (POMV) can help formulate strategies to reduce it. Implementing evidence-based practices, utilizing guidelines from professional organizations, e.g., American Society of Anesthesiologists, to standardize practices such as the use of multimodal analgesia to reduce opioid consumption and associated side effects. Team training and communication. Implementing simulation training to enhance teamwork and communication among the surgical and anesthesia teams, thereby improving crisis response. For example, conducting mock codes for potential emergencies can prepare the team for real-life situations. Patient feedback mechanisms. Establishing systems for obtaining and analyzing patient feedback regarding their anesthesia experience can highlight areas needing attention, such as communication about anesthesia risks. Regular performance review. conducting regular performance reviews to evaluate adherence to CQI protocols and ensuring that team members are engaged in the improvement process. Example implementation. One successful CQI initiative involved standardizing preoperative assessments across a surgical center to ensure comprehensive evaluations and minimize cancellations due to unaddressed medical conditions. This approach led to improved patient throughput and satisfaction. How does simulation training improve crisis management in anesthesia practice, and what are some key components of effective simulation scenarios? Answer. Simulation training enhances crisis management in anesthesia practice by providing realistic, immersive experiences that foster skill development and team dynamics. Key components include realistic scenarios. Scenarios should reflect common anesthesia emergencies, e.g., malignant hypothermia, airway obstruction, to ensure relevance and applicability. Multidisciplinary involvement, engaging various team members, anesthesiologists, surgeons, nurses, fosters better communication and understanding of roles during a crisis. Debriefing sessions. Following simulations, structured debriefing allows participants to discuss what occurred, identify strengths and areas for improvement, and reinforce learning. This reflective practice is crucial for solidifying knowledge. Feedback mechanisms. Providing constructive feedback during debriefings helps participants understand their performance and develop critical thinking skills necessary for effective crisis management. Practice in a safe environment. Simulation training allows for practice without risk to real patients, encouraging participants to make mistakes and learn from them in a controlled setting. Mr. Thompson is a 55-year-old male undergoing laparoscopic cholecystectomy. He has a significant history of obesity, BMI 35, and sleep apnea. What anesthetic considerations should be taken into account for Mr. Thompson? Answer. Anesthetic considerations for Mr. Thompson include preoperative evaluation, assess for any other comorbidities, e.g. cardiovascular issues, and evaluate the severity of his sleep apnea using a sleep study report. Airway management. Due to obesity and sleep apnea, anticipate potential airway difficulties. Prepare for potential intubation challenges and consider the use of video laryngoscopy. Anesthetic technique. Consider using a regional technique such as a transversus abdominis plane tap block in addition to general anesthesia to minimize opioid requirements and associated respiratory depression. Monitoring. Employ advanced monitoring techniques including capnography and continuous pulse oximetry to monitor for signs of hypoventilation or desaturation. Postoperative care. Implement strategies to manage postoperative pain while minimizing respiratory depression, such as the use of multimodal analgesia, non-opioid analgesics, nerve blocks. Patient education. Educate Mr. Thompson on the importance of postoperative monitoring and the use of continuous positive airway pressure (CPAP) if prescribed. Explain how understanding pharmacokinetics and pharmacodynamics influences drug selection and dosage in anesthesia. Answer. Understanding pharmacokinetics, how drugs move through the body, and pharmacodynamics, how drugs affect the body, is critical in anesthesia for several reasons. Drug selection. Knowledge of the pharmacokinetics of anesthetic agents, e.g. onset, peak effect, duration, allows anesthesiologists to select appropriate agents based on the procedure's duration and patient factors, e.g. liver or kidney function. Dosage calculation. Anesthesia providers must consider patient-specific factors, age, weight, comorbidities, to calculate accurate dosages, particularly for agents with narrow therapeutic indices. Individual response variability. Understanding how genetic variations affect drug metabolism, pharmacogenetics, can help predict individual responses to anesthesia and avoid adverse reactions. Effects of drug interactions. Recognizing how co-administered medications can alter the pharmacokinetics of anesthetics, e.g. enzyme inhibition or induction, is vital for avoiding potential complications. Clinical monitoring. Knowledge of the pharmacodynamic effects of anesthetics informs the continuous monitoring of vital signs and the adjustment of dosages during the procedure to maintain optimal anesthesia depth. Discuss the implications of resource allocation in anesthesia care and how disparities may affect patient outcomes. Answer. Resource allocation in anesthesia care is a critical issue with significant implications for patient outcomes, access to care. Disparities in resource allocation, e.g. access to anesthesia providers, technology, and facilities, can lead to inequitable access to surgical care, particularly in underserved communities. Quality of care. Limited resources may impact the quality of care provided, leading to longer wait times, inadequate preoperative assessments, and increased risk of complications due to rushed or inadequate anesthesia management. Ethical considerations. Ethical dilemmas arise when deciding how to allocate limited resources effectively. Outcome disparities. Studies have shown that patients from lower socioeconomic backgrounds may experience worse outcomes due to disparities in anesthesia care, including higher rates of postoperative complications and lower satisfaction. Policy implications. Advocacy for policies that promote equitable resource distribution, increased training for anesthesia providers in underserved areas, and enhanced access to quality care is essential for improving patient outcomes. Describe the role of safety protocols in anesthesia practice and provide examples of protocols that enhance patient safety. Answer. Safety protocols in anesthesia practice are designed to minimize risks and enhance patient safety through standardized procedures. Examples include preoperative checklists, utilizing checklists before procedures to ensure all necessary assessments and preparations are completed, reducing the risk of errors. The World Health Organization, WHO surgical safety checklist is a widely adopted example. Anesthesia machine checks, implementing protocols for routine checks of anesthesia machines and equipment to ensure functionality and safety before each use. Standardization of medications, establishing protocols for the preparation and administration of medications to prevent errors, including the use of color-coded labels for high-risk drugs, e.g. anesthetics, opioids. Incident reporting systems, creating systems for reporting and analyzing adverse events and near misses to identify trends and implement corrective actions. Education and training, regular training sessions for anesthesia providers on safety protocols and crisis resource management to ensure readiness for emergencies. During a complex cardiac surgery, the anesthesiologist encounters unexpected hypotension despite adequate fluid resuscitation. What steps should be taken to assess and manage the situation? Answer. In response to unexpected hypotension during cardiac surgery, the following steps should be undertaken. Immediate assessment. Quickly assess the patient's hemodynamics using invasive monitoring, e.g. arterial line, to determine blood pressure trends and heart rate, identify potential causes, evaluate potential causes of hypotension, including volume depletion, assess for ongoing blood loss or inadequate fluid resuscitation. Cardiac function, evaluate the patient's cardiac status, including potential myocardial depression due to anesthetic agents or surgical manipulation. Vasodilation, consider the effects of anesthetic agents causing vasodilation. Interventions, implement appropriate interventions based on the identified cause. If hypovolemia is suspected, administer additional IV fluids or blood products. If myocardial depression is present, consider inotropic support, e.g. dobutamine to enhance cardiac output. If vasodilation is suspected, administer vasopressors, e.g. norepinephrine to stabilize blood pressure. Consultation. Engage with the surgical team for any necessary interventions that may address surgical causes of hypotension, e.g. bleeding control. Ongoing monitoring. Continuously monitor the patient's vital signs and adjust the anesthesia plan as needed to maintain hemodynamic stability. Explain the physiological changes that occur with aging and their implications for drug dosing in geriatric patients. Answer. As patients age, several physiological changes impact pharmacokinetics and pharmacodynamics, necessitating adjustments in drug dosing. Key changes include decreased renal function, GFR decreases, leading to reduced clearance of renally excreted drugs. This increases the risk of drug accumulation and toxicity, alter hepatic metabolism, liver size and blood flow decline, affecting the metabolism of drugs that undergo first-pass metabolism. Dosage adjustments may be required for medications like opioids and benzodiazepines. Changes in body composition, increased body fat percentage alters the volume of distribution for lipophilic drugs, leading to prolonged half-lives. Conversely, total body water decreases, affecting hydrophilic drugs. Pharmacodynamic changes, sensitivity to certain medications can increase with age, e.g. benzodiazepines leading to sedation, while others may have a reduced effect, e.g. beta blockers. Guidelines. The American Geriatric Society provides recommendations for medication use in older adults, emphasizing the need for careful evaluation of drug regimens, particularly for those with multiple comorbidities. What are the anesthetic considerations for patients with pulmonary hypertension undergoing surgery? Answer. Anesthetic management for patients with pulmonary hypertension involves several critical considerations. Preoperative assessment. A thorough evaluation of cardiac function and pulmonary status is essential. Patients may require optimization of their pulmonary hypertension treatment before surgery. Maintenance of hemodynamics. It is vital to avoid any intraoperative events that could worsen pulmonary hypertension, such as hypoxia, hypercapnia, or acidosis. Continuous monitoring of hemodynamics and arterial blood gases is crucial. Anesthetic agents, use of agents that maintain or enhance systemic vascular resistance is preferred. For example, agents like etomidate or propofol may be avoided if they cause significant vasodilation. Intraoperative management. Utilize short-acting medications for rapid titration and to allow for hemodynamic stability. Nitric oxide may be considered for intraoperative management if pulmonary hypertension is severe. Guidelines. The American College of Cardiology, American Heart Association, ACOHA, describe the anesthetic implications for patients with neurological disorders undergoing craniotomy. Answer. Patients with neurological disorders, such as dementia or neurodegenerative diseases, present unique challenges during craniotomy due to altered brain physiology and potential complications. Important considerations include preoperative evaluation, assess cognitive function, neurological status, and the potential impact of anesthesia on pre-existing conditions. It may be necessary to involve a neurologist in the preoperative planning. Choice of anesthetic. Consider using agents with minimal cognitive side effects. Inhaled anesthetics and long-acting benzodiazepines may exacerbate postoperative confusion. Neuroprotection strategies. Maintain cerebral perfusion and oxygenation throughout the procedure. Techniques such as moderate hypothermia may provide neuroprotection. Postoperative care. Close monitoring in the PACU is essential as patients may experience prolonged recovery times and cognitive dysfunction postoperatively. Guidelines. The American Society of Anesthesiologists, the SAP, provides guidelines for managing patients with neurological disorders, emphasizing the need for tailored anesthetic plans to minimize cognitive decline. Mr. Thompson, a 72-year-old patient with a history of heart failure and COPD, is scheduled for elective hip replacement surgery. What anesthetic considerations should the anesthesiologist take into account for Mr. Thompson? Answer. Mr. Thompson's comorbidities significantly impact his anesthetic management. Key considerations include cardiac evaluation. Assess cardiac function, including echocardiogram findings, to evaluate ejection fraction and potential risks of perioperative cardiac events. Pulmonary management. Given his COPD, preoperative optimization may involve bronchodilator therapy, corticosteroids, and possibly the use of CPAP if he has obstructive sleep apnea. Anesthetic technique. A regional anesthesia approach, e.g., spinal or epidural, may be preferable to minimize the risks associated with general anesthesia, particularly the respiratory effects of sedation. Monitoring and medications. Continuous cardiac monitoring and preparedness to manage any arrhythmias or hemodynamic changes intraoperatively is essential. Consider avoiding respiratory depressants, such as certain opioids, and using multimodal analgesia for pain management. How does obesity complicate airway management during anesthesia? Answer. Obesity complicates airway management due to several anatomical and physiological factors. Altered anatomy. Excess fat deposits in the neck and oropharyngeal area can lead to a more difficult intubation due to limited visibility and potential for airway obstruction, increased risk of difficult bag mask ventilation. The higher likelihood of obstructive sleep apnea increases the risk of inadequate ventilation during induction. Pharmacokinetics. Obese patients may require higher doses of anesthetics due to increased volume of distribution for lipophilic drugs, but dosages must be carefully calculated to avoid overdose. Postoperative complications. Obese patients are at increased risk for respiratory complications postoperatively, necessitating careful monitoring and potentially the use of non-invasive ventilation strategies. Guidelines. The ASA recommends that anesthesiologists employ a multidisciplinary approach for the management of obese patients, including preoperative assessments and tailored anesthetic plans. What is the role of continuous positive airway pressure, CPAP, in the perioperative management of patients with obstructive sleep apnea, OSA? Answer. CPAP plays a crucial role in the perioperative management of patients with OSA by providing preoperative optimization. Use of CPAP before surgery can stabilize a patient's respiratory status, reducing the risk of perioperative complications related to OSA. Intraoperative management. Continuation of CPAP intraoperatively can help maintain adequate oxygenation and prevent airway obstruction during anesthesia, particularly in prone or supine positions. Postoperative care. Early resumption of CPAP in the PACU can help minimize respiratory complications such as hypoxemia or apnea that are common in OSA patients. Guidelines. The ASA endorses the use of CPAP as part of a comprehensive management strategy for patients with OSA undergoing surgery, highlighting the importance of continuity of care. Discuss the anesthetic considerations for managing labor analgesia in obstetric patients. Answer: managing labor analgesia requires careful consideration of maternal and fetal safety, assessment of pain, evaluate the intensity and characteristics of the patient's pain and their preferences for pain management. Choice of analgesia. Options include epidural analgesia, spinal analgesia, and systemic opioids. Epidural analgesia is often preferred due to its effectiveness and ability to provide continuous relief. Monitoring. Continuous fetal monitoring is essential to assess fetal well-being and detect any adverse effects of analgesia on the fetus. Medication safety. Be mindful of the effects of analgesics on both the mother and the neonate. For instance, avoid using high doses of opioids due to the risk of respiratory depression in the newborn. Guidelines. The American College of Obstetricians and Gynecologists (ACOG) provides guidelines on the use of labor analgesia, emphasizing individualized care based on the patient's medical history and preferences. What challenges are associated with trauma anesthesia, particularly in managing difficult airways? Answer: trauma patients often present unique challenges in anesthesia due to potential airway complications. Rapid sequence induction (RSI). Due to the risk of aspiration from full stomachs or altered consciousness, RSI techniques are crucial, using medications that provide rapid sedation and paralysis. Difficult airway management. Trauma can lead to anatomical distortions, e.g., from facial injuries, that complicate intubation. Anesthesiologists should prepare for alternative airway management strategies, such as video laryngoscopy or supraglottic airway devices. Hemodynamic instability. Trauma patients may have significant blood loss or fluid shifts, requiring rapid assessment and stabilization before anesthesia. Monitoring. Ensure continuous monitoring for signs of respiratory distress, hypoxia, or hemodynamic instability throughout the procedure. Guidelines. The ASA provides protocols for the management of trauma patients, emphasizing the need for quick assessments and readiness for difficult airway situations. Explain the anesthetic implications for patients undergoing cardiac surgery and the management of cardiopulmonary biopsy. Answer: patients undergoing cardiac surgery require careful planning regarding anesthetic techniques and CPB management. Preoperative considerations. Thorough assessment of the patient's cardiac function is critical. Evaluation may include echocardiography and stress testing to determine functional capacity. Anesthetic technique. General anesthesia is typically used with agents that maintain hemodynamic stability. Opioid-sparing techniques and regional anesthesia may be beneficial for postoperative pain control. Management during CPB. Anesthesiologists must ensure adequate anticoagulation to prevent thromboembolic events. Monitoring for hemodynamic changes during CPB is essential, as patients may experience shifts in blood volume and cardiac output. Postoperative care. Patients require close monitoring for signs of cardiac instability, arrhythmias, and respiratory complications following extubation. Guidelines. The Society of Thoracic Surgeons and ASA provide guidelines for cardiac anesthesia, emphasizing multidisciplinary approaches to perioperative care for cardiac surgery patients. What are the anesthetic challenges associated with regional anesthesia for orthopedic surgeries, and how can they be addressed? Answer: regional anesthesia for orthopedic surgeries presents specific challenges. Patient positioning. Proper positioning is essential to prevent nerve injuries during the procedure, especially in lower limb surgeries. Anesthesia providers must ensure adequate padding and support. Choice of block. Selection of the appropriate nerve block, e.g., femoral nerve block for knee surgery, is critical. Consider factors such as patient anatomy, surgical site, and the potential need for postoperative analgesia. Complications. Potential complications include hematoma formation, infection, or nerve damage. Anesthesiologists should be prepared to manage these risks through careful technique and monitoring. Postoperative pain management. Implement multimodal analgesia strategies that combine regional blocks with systemic medications to enhance pain control and reduce opioid use. Guidelines. The American Society of Regional Anesthesia and Pain Medicine offers recommendations on the safe and effective use of regional anesthesia, emphasizing careful planning and patient-specific approaches. What are the indications for advanced monitoring techniques during intraoperative management, and how do they impact patient outcomes? Answer: advanced monitoring techniques are utilized in high-risk surgical procedures or in patients with significant comorbidities. Indications include invasive arterial lines are indicated for continuous blood pressure monitoring in patients with labile hemodynamics or those undergoing major surgery, e.g., cardiovascular orthopedic. Central venous pressure (CVP) monitoring is used to assess fluid status and guide fluid therapy, especially in patients with heart failure or major fluid shifts. Neurophysiologic monitoring is indicated in surgeries involving the central nervous system to prevent neurological deficits. These advanced techniques enable real-time monitoring, which is crucial for early detection of complications and can improve patient outcomes by allowing timely interventions. Relevant guidelines. The American Society of Anesthesiologists (ASAP) recommends the use of advanced monitoring techniques in specific scenarios, particularly in high-risk patients or procedures where significant physiological changes are expected. What are the key considerations in fluid management strategies during anesthesia maintenance, particularly regarding the choice between crystalloids and colloids? Answer: fluid management during anesthesia maintenance is critical for maintaining hemodynamic stability. Key considerations include type of surgery. Major surgeries often require more aggressive fluid replacement, patient status, preoperative hydration status, comorbidities e.g. renal dysfunction and ongoing losses e.g. bleeding should guide fluid selection. Crystalloids versus colloids. Crystalloids e.g. normal saline lactated Ringer solution are commonly used for their availability and low cost. They distribute quickly to the extracellular space but may require larger volumes. Colloids e.g. hydroxyethyl starch albumin can be used for rapid volume expansion in cases of significant blood loss but may be associated with higher costs and risks of allergic reactions. Guidelines. The ASA guidelines suggest using balanced crystalloid solutions for routine fluid management, with colloids reserved for specific clinical scenarios where rapid volume expansion is necessary. Mr. Thompson is undergoing a laparoscopic cholecystectomy. During the procedure, the anesthesiologist observes sudden hypotension. What steps should the anesthesiologist take to manage this situation effectively? Answer: in the event of sudden hypotension during surgery, the anesthesiologist should take the following steps. Immediate assessment. Evaluate the patient's monitoring data, including blood pressure, heart rate, and oxygen saturation. Identify potential causes of hypotension, e.g. hypovolemia, anesthesia effects, surgical manipulation, positioning. If the patient is not already in the Trendelenburg position, consider repositioning to enhance venous return. Fluid resuscitation. Administer intravenous fluids, starting with crystalloids, to address potential hypovolemia. Monitor response to fluid administration. Pharmacologic interventions. If hypotension persists, consider administering inotropes, e.g. ephedrine, or vasopressors, e.g. phenylephrine, to restore hemodynamic stability. Consult surgical team. If hypotension is related to surgical factors, e.g. bleeding, communicate with the surgical team for immediate intervention. Relevant protocols. The ASA guidelines emphasize the importance of recognizing and managing intraoperative hypotension promptly, with fluid resuscitation and vasopressor therapy as standard interventions. How should an anesthesiologist recognize and manage bronchospasm during anesthesia, and what specific interventions are indicated? Answer: bronchospasm can occur intraoperatively, particularly in patients with a history of asthma or reactive airway disease. Key recognition and management steps include recognition. Signs of bronchospasm include increased peak airway pressures, wheezing on auscultation, and difficulty maintaining tidal volumes. Monitoring waveform changes on capnography can also indicate bronchospasm. Immediate interventions: increase oxygenation, administer supplemental oxygen, and ensure adequate ventilation. Bronchodilators: administer a rapid-acting bronchodilator such as albuterol via a nebulizer or metered-dose inhaler and DI. Anesthetics adjustment: consider deepening anesthesia if the bronchospasm is due to airway irritation from the endotracheal tube. Use intravenous anesthetics to provide additional sedation. Consider corticosteroids. If bronchospasm persists, systemic corticosteroids, e.g. methylprednisolone, may be administered. What are the clinical implications of anaphylaxis during anesthesia, and what protocols should be followed for recognition and treatment? Answer: anaphylaxis during anesthesia is a life-threatening condition requiring immediate recognition and management. Clinical implications include recognition. Symptoms of anaphylaxis may present as hypotension, tachycardia, urticaria, and bronchospasm. Monitoring for changes in vital signs and oxygenation is crucial. Immediate protocols: administer epinephrine. The first-line treatment is the immediate administration of epinephrine 0.3–0.5 mg of 1,000 solution intramuscularly. For adults, this may need to be repeated every 5 minutes depending on response. Supportive care: provide airway support, intravenous fluids, and additional medications, e.g. antihistamines, corticosteroids, as indicated. Post-anaphylaxis care. Monitor the patient closely after anaphylaxis for recurrence of symptoms and consider referral for allergy testing postoperatively. Relevant protocols. The ASAS practice guidelines emphasize the importance of recognizing anaphylaxis quickly and having emergency drugs readily available in the operating room. What are the key factors to consider when assessing hemodynamic instability during surgery, and how should an anesthesiologist address these issues? Answer. Key factors to assess hemodynamic instability include monitoring parameters. Continuous monitoring of blood pressure, heart rate, and central venous pressure is essential. Sudden changes in these parameters may indicate hemodynamic instability. Fluid status. Assess intravascular volume using clinical signs e.g. urine output, skin turgor, and monitoring devices. Causes of instability. Identify potential causes such as hypovolemia, myocardial infarction, or medication effects e.g. vasodilators. Management strategies. Fluid resuscitation. Administer crystalloids or colloids based on the assessed cause. Vasopressors inotropes. Use medications such as norepinephrine or dopamine to support blood pressure and cardiac output as needed. Consider surgical factors. Work with the surgical team to address any bleeding or fluid loss during the procedure. How does malignant hypothermia present in a surgical patient, and what is the standard protocol for its management? Answer. Malignant hypothermia is a genetic disorder triggered by certain anesthetic agents e.g. halothane, succinylcholine, and presences. Clinical presentation. Symptoms include rapid increase in end-tidal carbon dioxide, echo, muscle rigidity, tachycardia, and hypothermia, core temperature exceeding 38.5 Dic. Management protocol. Immediate action. Discontinue all triggering agents and initiate active cooling measures e.g. cooling blankets, ice packs. Administer dantrolene. The specific treatment for malignant hypothermia is dantrolene sodium, administered as 2.5 dag IV, repeated as necessary until symptoms improve. Supportive care. Provide supportive care, including fluids and monitoring for potential complications such as renal failure. Guidelines. The ASA guidelines outline the importance of having a malignant hypothermia cart readily available in operating rooms, including dantrolene and emergency equipment. What are the implications of pulmonary edema in a patient undergoing anesthesia, and how should the anesthesiologist approach its management? Answer. Pulmonary edema during anesthesia can lead to significant respiratory complications. Implications include impaired gas exchange, hypoxemia, and potential respiratory failure. Management should include recognition. Signs of pulmonary edema may include increased work of breathing, crackles on auscultation, and decreased oxygen saturation. Immediate management. Positioning. Elevate the patient's head to facilitate breathing. Oxygen therapy. Administer supplemental oxygen and consider positive pressure ventilation, CPAP or BiPAP, if the patient is in severe distress. Diuretics, if indicated and the patient has a history of heart failure or fluid overload. Administer diuretics e.g. furosemide to decrease fluid overload. Fluid management. Assess and manage fluid balance carefully during and after surgery to prevent exacerbation of pulmonary edema. Relevant protocols. The ASA emphasizes the importance of managing pulmonary edema by addressing underlying causes and providing supportive care. What are the clinical considerations and protocols for managing postoperative nausea and vomiting (PONV) in surgical patients? Answer. PONV is a common complication that can impact patient recovery. Clinical considerations include risk assessment. Identify patients at high risk for PONV based on factors such as history of motion sickness, female gender, and the use of certain anesthetics e.g. nitrous oxide. Preventive measures, medication. Use antiemetic prophylaxis e.g. ondansetron, dexamethasone, based on the risk profile. Multimodal approach. Consider combining pharmacologic and non-pharmacologic measures e.g. acupressure, hydration. Postoperative management. Monitor for symptoms of PONV, and if they occur, treat with rescue antiemetics as needed. Guidelines. The ASA guidelines recommend a multimodal strategy to minimize the incidence of PONV and improve patient satisfaction. How should the anesthesiologist interpret and utilize monitoring data during surgery to ensure optimal patient safety? Answer. Interpreting monitoring data involves continuous analysis. Anesthesiologists must continuously analyze vital signs e.g. blood pressure, heart rate, echo, and waveform data from monitors to assess the patient's hemodynamic status and ventilation. Identifying trends. Look for trends rather than isolated readings to detect early signs of deterioration. Clinical correlation. Correlate monitoring data with clinical observations to ensure a comprehensive assessment. For example, an increase in heart rate and a drop in blood pressure may indicate hypovolemia or an adverse reaction to medications. Protocol adherence. Follow established protocols for monitoring, e.g. ASA standards for intraoperative monitoring, which outline minimum requirements based on the type of procedure and patient status. Guidelines. The ASA provides specific guidelines on monitoring standards, emphasizing that continuous monitoring is crucial for patient safety and timely intervention.